Hi, good evening, everybody. It is past, so we are going to get going. Welcome to this evening's Open Hand Therapy webinar. My name is Erica Coneybear, and I am your host for this evening. I'm very excited to be joining you from all the way up in Zim. I'm on leave at the moment, so I'm visiting family up here. This webinar is brought to you in association with the University of the Witwatersrand and the South African Society for Hand Therapists. This evening's topic is managing the median nerve. We have two presenters who will be talking to, the first one will be introducing the median nerve injuries and speaking specifically about regaining motion, and our second presentation will be on sensory re-education after median nerve repair. And afterwards, there'll be a time for questions and discussions, but just a reminder to please put any questions you have in the chat. So let's get started with this evening's webinar. So I'm just going to stop sharing. We are very fortunate this evening to have our in-house team presenting. So Nicola and Kirsty, who are both familiar faces from the Open Hand Therapy team, are presenting on the median nerve. So Nicola has presented for us before last year. So for those of you who haven't met her yet, she is an occupational therapist and she's been faithfully working in the public sector at Leratong Hospital for the past 13 years. She did her hand therapy diploma at the University of Pretoria and completed that in 2017. Some things you might not know about Nicola is that she is a coding whiz, and she designed and set up our website. And she's created all of these amazing Excel spreadsheets that you just click a button and it imports all of your registration info in, and it makes sure all your CPD points get allocated correctly. So we are very fortunate to have some coding imported into making our system smooth. In her free time, she enjoys rock climbing, running, and playing piano. So Nicola, you can share your screen and get going as soon as you're ready. Thank you, everybody. I hope you enjoy it.
Thank you very much. Okay, so today I'm going to be talking about an introduction to median nerve injuries, and then I'm going to be specifically focusing on regaining motion after a median nerve injury. And then after that, we'll hear from Kirsty about sensory re-education. Okay, so these are just some of the objectives for my presentation. Okay, so the first thing I want to do is just talk about a bit about what a median nerve injury means for a patient. So we need to understand what the patient can't do and how this is going to affect their life. So you can see here, I've got a picture of the median nerve. So we're specifically talking about wrist level lacerations. So that means all of these muscles here are not going to be working. So the first and second lumbricals is not really such a big problem. Their loss isn't really that noticeable. But for these three muscles here, that is the ones we need to focus on. So we have abductor pollicis brevis, opponens pollicis, and the superficial head of flexor pollicis brevis, because the deep head is supplied by the ulnar nerve. So what these muscles do is they position the thumb for function. So they're responsible for palmar abduction and opposition. And what this does is it allows you to put your thumb in you want to pick up objects of any size. So this is what it looks like if these muscles are not working. So this lady had a zone 5 flexor tendon and median nerve repair. She was stabbed. So you can see that when she flexes her thumb, it's flexing very much into her hand. She's not able to get that abduction. So that's going to make it very difficult for her to pick up objects. So I actually took a video here of her trying to pick up objects just to show you what that looks like. So you can see that her movement is quite clumsy. You can see it's not very accurate. It's like quite a challenge for her. It's quite slow. Then another thing that you can see if you look carefully at the video is she's actually bending her wrist quite a bit while she's trying to do this. So the reason that she's bending her wrist is that lets her use abductor pollicis longus to at least try to get some thumb abduction. And this is a trick movement that you might notice that your patients will use. So with this patient, you can see it actually looks quite different in the median nerve injury. So he essentially has the same diagnosis. It's also zone 5 flexor tendon and median nerve repair. But you can see he can position his thumb quite nicely. He can get quite good abduction. So the reason for this is that in some patients, the innervation of flexor pollicis brevis is actually quite variable. So more of this muscle might be innervated by the ulnar nerve, and this is what gives them the ability to get better abduction. But even though you can abduct his thumb, you can still see he's not getting true opposition. So true opposition is if the nails of the thumb and the finger can touch each other like that. But for him, he's touching on the side of his finger. But he is going to manage a bit better with motor function after his injury because he can position his thumb a bit better. Okay, so that's the motor function, but the motor function is actually not nearly as serious to lose as the sensation. So you can see here in this picture, this is the sensory distribution of the median nerve. And this part of our hand is really important for picking things up, for touching, feeling, manipulating things. And this is what makes the sensory fallout after a median nerve injury such a big problem. So one of the first things we think about is that a patient will struggle with object recognition. But sensation really is about a lot more than that. So just at a basic level, the patient needs protective sensation so that they can tell if they're hurting themselves. So you can see for Neo, he ended up getting a wound on his finger because he probably touched something hot without realizing. And this is something that you can watch out for. So you might end up with patients coming with these wounds on the tips of their fingers, and usually they will have no idea where the wound even came from. And then sensation is also important for coordination. So if you can imagine, for example, that you're holding a key and you want to move the key in your hand to be able to unlock a door. As you're moving the key, you can feel what the position of the key is, and then you can move it a bit more, move it a bit more, feel, until you've got it in the right position. And then something else that we don't think about much if we think of loss of sensation is braiding of movements. So because we can feel what we're holding, we can feel exactly how hard we have to hold it. So that we can hold it with just the right amount of force that it doesn't slip, but also not too much force that we become tired. So this is going to be especially a problem with something like writing. So you'll often find patients with a median nerve injury will complain that they get very tired if they have to write. And part of the reason for this is they're probably holding the pen too tight because they can't feel how hard they're holding it. And this is also going to be a problem with handling things that are very fragile. So we will know exactly how hard to hold something that it doesn't fall, but it also doesn't break. But someone with a median nerve injury is going to struggle with that. Then there's just one other thing that I wanted to briefly mention here. So the median nerve also supplies the sweat glands of this part of the skin. So you might find that patients will have very dry skin after a median nerve injury. And this isn't too much of a problem. If they moisturize their skin, it will be fine, but it is something that patients often ask me about. Okay, so we've got motor loss and sensory loss, but I'm going to argue tonight that the biggest problem after a median nerve injury is neither of those. The biggest problem is actually the brain. So what the brain has to do is it has to take this massive amount of sensory input from the skin, and then it has to coordinate very fine movements using all the very many muscles that are controlled in the hand. And your brain has learned over the course of your life to move in very precise, exact ways. So it has very smooth, coordinated movements, and the way it moves is very energy efficient. But after a median nerve injury, this is all going to change. So some of these muscles are not going to be working anymore. So these very smooth, coordinated patterns that your brain has developed over time are not actually going to be very helpful. There's going to be a restricted repertoire of hand movements. So instead, your patient is going to be using compensatory movement patterns. So these patterns might be things like more mass grasps rather than precision grasps. And they might use both hands to manipulate objects. And this is going to be even more of a problem for your brain to learn these new movements because your brain doesn't have the sensory and proprioceptive feedback that it needs to be able to develop new movements and to figure out new movements better. So all in all, this is end up being very frustrating for your patient. They're going to take a long time to do things, and it's going to take a lot of effort. And if we don't address these problems at the level of the brain, then the patient is going to be at risk of ignoring their hand, and this is going to lead to a poor outcome. Okay, so we've seen something of what a median nerve injury looks like and how it affects our patients' lives. So next we're going to look at what recovery from a median nerve injury looks like, and we're going to see how we can optimize this recovery process. So I'm sure you're all very familiar with drawings like this, so I'm not going to go into too much detail here. So the main thing that I want to point out here is that the nerve at this level is made up of tens of thousands of axons. And the axons are what carry messages between the body and the brain. So the axon is surrounded by Schwann cells and then by an endoneurium. Okay, so here we're going to zoom into one specific axon, and we're going to say that the axon was injured over here. So when an axon is injured, it can't conduct messages anymore. And when it's injured like that, there is not a way for the axon to repair itself. So this segment and this segment can't become fixed again. Instead, what happens is this part has to disintegrate or degenerate from here all the way to the end. So you can see this picture is showing that happening. So when it disintegrates, it makes a bit of a mess. Then the Schwann cells have to come along and the macrophages and that to clean up the mess. And then what you're left with after that is an empty tube. So the endoneurium and then the Schwann cells form this empty tube. The proximal part of the axon forms a growth cone that sends out all these projections. So if one of the projections manages to go into this empty tube, then it will keep on going like that, and then eventually it's going to reach the muscle or the skin or whatever it was going to. So the reason that I wanted to show you this slide is to just explain why it takes so long for a nerve to recover. So first, this process of cleaning up and disintegrating and cleaning up already takes a few weeks. So already in the first few weeks, you're not expecting to see any recovery. Then after that, the axon has to grow back, and it grows back at around 1 millimeter a day, which is very slow progress. So it's important for your patients to understand what is happening so that they know why it's taking so long for it to see any signs of reinnervation. And with a median nerve injury at the wrist, you might be looking at even as much as 3 to 4 months before you see any signs of recovery. The recovery is also going to depend on how badly the nerve was damaged. Okay, so if it was a crush or a stretch injury, so this we refer to as an axonotmesis. So here the nerve is damaged, but it's still in continuity. And it can be from something like a fracture or a gunshot wound. But with these sort of injuries, the endoneurium is intact because the nerve is still in continuity. So the axon can regenerate, it can go along that empty tube, and then eventually it's going to reach that nerve or muscle or whatever it was that it was going to innervate. And for these injuries, no surgery is needed, and we're going to expect the recovery to be faster and also to be more complete. But with median nerve injuries, what we see a lot more commonly is a complete laceration. This is where the nerve is totally cut, and we call that a neurotmesis. And because the median nerve is surrounded by tendons, it's actually really unlikely that just the median nerve is injured. Usually a lot of tendons are going to be injured as well. So if the nerve is completely cut, it does need surgery in order to recover. If the patient doesn't have surgery, then the axons will still regrow, but they don't have a tube to grow into again because the nerve isn't together anymore. So you're not expecting to see any signs of recovery. But if the patient doesn't have surgery, there are still things that we can do to help them to compensate for the loss of function, and we'll talk more about that later. If the patient does have surgery, then what's going to happen is the doctor is going to sew the nerve back together again. But it's impossible for the doctor to line up the nerve exactly like it was before. So that means that the axon is going to regenerate, and it's going to go into a tube all the way to the skin or the muscle, but it's not necessarily going to go into the same tube that it did previously. So for example, you might have an axon that used to innervate operculus pollicis. Maybe now it's going to go into a tube that's going to take it to abductor pollicis brevis. So this is going to make it a bit more confusing than its two poorer results. Okay, so we've said that the brain is a very important part of a nerve injury. So we need to understand how the things that we've spoken about are going to affect the brain. So this is a representation of the body on the either the somatosensory or motor cortex. So what happens after a nerve injury is there's an immediate black hole. So this area here is probably what corresponding to the median nerve. And this area is going to become completely silent. So because it's completely silent, with time, the other areas of the brain, the adjacent areas, are going to start to take over. They're going to get smaller. And this starts to happen even within a few minutes of the injury. So one of our aims of therapy is going to be to try to maintain this area so that it doesn't lose this representation. And we can do that just to do that as much as possible. And then another problem is, so we said that the muscles on the brain are going to be represented in quite a logical, orderly sort of fashion. So operculus pollicis, there's going to be a specific area of the brain that can control that. But we said that when the nerve is repaired, the recovery is going to be a little bit all over the place. So maybe the axons that previously went to operant polycis might now end up in a different muscle. So that's going to mean that the brain is not exactly going to know what axons to send a message along to control which muscle. So that's going to lead to this very mixed picture in the brain. It's like this patchwork. And it's almost like the hand is speaking a different language, and the brain is having a really tough time trying to understand what the hand is saying. And part of our aim of therapy is going to be to try to teach the brain to understand the hand a bit better. But these problems in the brain are actually the main reason why we're not expecting patients to recover completely from a nerve injury. Even if the patient has surgery immediately and it's the best possible surgical techniques, we still don't expect a full recovery because of the changes that happen in the brain. And I said here, we expect a suboptimal recovery in adults because in children it is a little bit different. So for children, they have a bit more neuroplasticity, so it's like their brain can learn a bit easier to speak the new language, to understand the new language that the hand is speaking. Okay, so now we've spoken about how the median nerve recovers. So now we're going to look at assessment and treatment that we can do to get the best possible outcomes for the patient during this recovery process. So these are some things to assess. I'm going to be covering the ones in black. Okay, so the first thing that we're going to look at is motor function. Now, the reason that we want to assess motor function is that we want to see if the nerve is starting to recover, if the muscles are starting to be innervated again. And we also want to know how strong the muscle is so that we can know what exercises that we can give our patients to do to improve the strength. So for motor function, we can use the same MRC grading scale that we use for other muscles. But for the fingers, it's suggested that resistance isn't really that, gravity isn't really that important because the weight of the finger is so small. So we can just look at movement and resistance. So when we assess motor function, we're going to start right here in the middle. So it can be a bit difficult sometimes to get the patient to move their thumb in a certain way. So the easiest way to do it is to just put the thumb in the position you want and to find out from the patient if they can keep it like that. So if you can put the thumb in abduction or in opposition and the patient can hold that position, then you know that they are grade 3. If they can't hold that position, then you're going to determine do they have reduced movement, a contraction only, or no movement. If they can hold the position, then you can start to add some resistance. If they can handle resistance, then you can even start looking at some strength testing. So we're mostly concerned about pinch strength. So you can use a pinch meter if you have one, but I usually just use a peg and I just get the patient to see how wide they can open the peg. Okay, then we're also going to assess dexterity. So dexterity is a combination of motor function, sensory function, but it also takes into account the brain's ability to compensate for any loss of motor and sensory function. So that means dexterity is something that can improve even if there is no recovery of the nerve. This is something that we can assess and work on before there are any signs of nerve recovery. And it's also something important to work on in patients who have not had surgery to repair the nerve, because this is something that we can still improve and we can still help them to recover with. So there are certain standardized tests for dexterity. But really all these tests do is get the patient to perform a specific in-hand manipulation task, like putting pegs in a pegboard, and then it's timed to see how long they take. So we don't really need to have something fancy like this. So these are some things that I have where I work, but if you don't have something like this, you can use something as simple as a container with a hole in the lid, and then either some pasta or some beans or something like that. So what we need to do to assess dexterity is just decide on a specific task and then time the patient doing it. So for example, how long does it take the patient to take 10 noodles and put them in the container one at a time? And the next time we test it, we can time it again and see if there's been an improvement. Then the most important thing that we need to assess is activities and participation. If we don't understand our patients' functional needs, then we're not going to be able to choose the right exercises for them to help them to be able to get back to the things that are important to them. And the ultimate goal of our therapy is really to get our patients to get back to their daily lives. And if we want to do that, we need to know what their daily lives look like. And we need to develop meaningful goals with them that we can work towards. And that'll also be very motivating for them. And it's also a patient-specific activities and participation that's going to determine what their therapy looks like. And so you can see with our 2 patients here, they essentially have the same injury, a flexor tendon and median nerve repair. But because they have different needs, their therapy is going to look very different. So for example, for Palesa, it's her non-dominant hand that's injured. We're going to be looking at her doing very advanced in-hand manipulation. We want more basic in-hand manipulation, and we want to work at her having the grips and grasps that she needs to support things with her left hand, while her dominant right hand works with them. For Neo, it's very different. It's his dominant hand that's injured. So he needs to develop a lot more precise in-hand manipulation. And then their needs for activities are also different. Palesa's priority is to get back to caring for her children, whereas Neo attends school, so he needs to get back to writing. So the activities and things that we do with them are going to be very different to be able to get them to reach their unique individual goals. Okay, so then we're going to talk about post-surgical management. So this is mostly about protecting the nerve after surgery. So if your patient doesn't need surgery, maybe it was an axonotmesis, the nerve wasn't cut, or if the patient doesn't have surgery available to them, then you can skip this section and move on to the next one. But if they had surgery, as I said, the main goal is to protect the repair. So we don't want to put tension on the repair. So if the wrist extends like this, it's going to pull on the repair, and that's going to be a problem. So we want to position the wrist in neutral to slight flexion. If just the median nerve is repaired, which is very rare, then we can leave the fingers free. But in pretty much every case, there are going to be flexor tendons that were repaired as well. And then you're going to make a splint that keeps the wrist in neutral to slight flexion, but it also needs to have a hood to protect the flexor tendon repair. And the splint can be of thermoplastic, like the ones I usually make, but you can also use plaster of Paris, depending on your preference or what you have available. And then the general recommendation for a nerve repair is that it should be immobilized for 3 weeks. So if only the median nerve is repaired, then after 3 weeks you are done with immobilization. But obviously for a flexor tendon repair, that is not going to be the case. You need to prioritize the flexor tendon repair guidelines. So the patient will still need to be wearing their splint at this stage. But there are some changes that you can start to make from about 3 weeks. So for example, you can adjust the splint to allow for more wrist extension, like I did here with Palesa. And you can also start to work on synergistic wrist motion. And these are just some other things that you can consider after surgery. Okay, so next we're going to look at the rehabilitation phase. So this is where we're starting to look for signs of nerve recovery, and we're also starting to focus a lot on function. We want to get the patient back to doing their activities of daily living, and we want to focus on functional improvements. If the patient had a flexor tendon repair, then you need to wait until they're allowed to use their hand before you can start with this. So you'll probably wait until about 5 or 6 weeks. But if the nerve wasn't repaired or didn't need to be repaired, then you can start with this a lot sooner. So these are the things we're going to be speaking about. Okay, so the first thing we can talk about just briefly is making sure the patient doesn't develop any contractures. So with a low median nerve injury, the contracture we're worried about is a first wave space contracture. So that would mean that the first wave space become tight and they don't allow the patient to have full passive thumb abduction. And obviously we want to stop this from happening, because if the nerve can recover, the muscles can work again. We want the patient to be able to get back to normal. So for someone like Neo who has good active abduction, we are not worried about a contracture. But if the patient is struggling with abduction, then we do need to assess their ROM and just make sure that everything is fine. We can teach them passive stretches. So with passive stretches, we should be pushing at the base of the thumb, not at the top here, and then just doing that maybe 2 times a day or so to make sure that range is maintained. And I usually find this is enough. But if you, for some reason, you find that it's not enough for your patient, you can do nighttime splinting as well. You can see this is just a small piece of thermoplastic around in the web space with a strap around it. Okay, then we get into more interesting stuff. So we want to also encourage functional use of the hand. So we need to get the patient to use the hand in activities as much as possible. And we help them to find realistic ways that they can do that based on the function that they have available. So at the beginning, they might just more be supporting things with their hand while they use the other hand or the non-injured hand for the more complicated tasks. And in the end, we want them to start using the hand more and more like they used to use it before. So using the hand for function is important for a few reasons. And the first reason is to do with the most important thing after a nerve injury, the brain. Using the hand is going to help to maintain the cortical representation of the hand, which is going to be important. Then also, using the hand is going to help for general upper limb mobility and strength. If the patient ignores the hand, they can start to develop weakness of their muscles. They might also start to mobility. Now, this is in muscles and joints that weren't even affected by the nerve injury. And we really don't want that to happen. And then also encouraging the patient to use their hand in function will help their function to improve. Then if we want the patient to use the hand more for function, then we can also find some ways to make it a bit easier for them to do this. And one way is splinting. So we said that what those muscles do is they position the thumb for function. So that is what our splints need to do as well. So I've put a whole lot of examples here of splints that you can use. So you can see these ones are made using a soft splinting material, like maybe leather or neoprene. You can use taping as well. And then you can also use thermoplastic like these ones here. So I've put here my 2 favorite splints, and I've put some extra pictures in just to explain to you how I make them. So with this one, it's a soft splint. I used ProWrap to make it, but you could also use any material that you have available and just some scrap pieces of Velcro sewn onto the material. So it's very simple. It's basically just a strap that goes around the wrist and then a strap that goes around the thumb. And you can just make sure, like it shows over here, that the thumb, the strap is around the base of the thumb, not over here, because that's not going to do much good. Okay, then this is my favorite thermoplastic splint. So you can see here, I drew a pattern to show you what it looks like when I make it. And then I also have my pattern over here. So this is what it looks like. So what I do is I cut this out of thermoplastic, and then I'm going to mold it to the patient's hand. So I'm going to put it around like that. That part goes in the web space. This part wraps around. And then I'm going to put a strap to hold this part and this part together. And I'm just going to make sure that here it's not too long, that it's not restricting movement of these joints. Okay, but do you need a splint? What splint do you make? So for Neo, because he had good thumb abduction, he could position his thumb nicely. A splint was probably just going to get in the way for him. So for him, I didn't make a splint. A Palesso could really do with some, just like a bit of help to try get that thumb moving a bit better and positioned a bit better. So we discussed her functional needs and we discussed her preferences, and we decided that a soft splint was going to be the way to go. So I took a video of her doing that same task as before with the splint on. So you can see that she's doing it a lot faster. And that was her favorite part of the splint, was the speed that she could work at. You can also see that she doesn't have to flex her wrist anymore to use abductor pollicis longus, because the splint is positioned in her thumb really nicely. Okay, then another important goal is to improve dexterity. So as we said, dexterity is going to be a problem for the patients because some of the muscles are not working. So the brain can't get the hand to use those same movement patterns that you've been using your whole life. So it needs to learn new movement patterns. So we need to practice these things so the patient can develop compensatory strategies. If the patient just uses the hand for everyday life, they will get to develop these strategies, but it's going to take a lot longer. It's much better if the patient can do focused practice to get it right. Then other important things to achieve with this is to maintain the cortical representation by using the hand. That will achieve that. And we also want to enhance cortical reorganization. So what I mean here is that when the nerve starts to recover, it starts innervating those muscles again. It's going to be very confusing for the brain to know exactly how to control those muscles because the innervation has changed. So maybe some of the axons that went to one muscle are now in a different muscle in a different place. But practice is going to help a lot with that. So as the patient uses their hand, the brain will learn how to control the hand better. So just some important things to think about with dexterity training. We want a lot of repetition because practice makes perfect. It can also help to grade activities. So for example, you can start with familiar objects and then move on to unfamiliar objects. You can start with larger objects and then go to smaller ones. And you can also start with more simple movements and move to more complex movements. Then a very important thing again is that we need to incorporate it into function. So the best way to do this is to choose activities that will directly be linked to the things that the patient wants to be able to achieve. So you're going to look at what things they are struggling with and find activities that will help them to get the skills they need to do those things again. So I'll put here some examples here of different dexterity activities that you can do. So all of these use resources that everyone should have available, and they're quite simple and easy to do. So if a patient is struggling with something like buttons, it might be better for them to do buttons off themselves first, because then at least they can use their vision a bit more. If they enjoy something like beading or like games or puzzles, that can also be something nice for them to do that is like very motivating and engaging for them. Okay. Then the last thing that we're going to speak about is improving motor function. So this is something that you're going to do when there are signs of reinnervation. So you're going to know that it's happening because you're going to be testing their muscle strength. So we have grade 2 strength, which means that they have partial movements, so those muscles are working just a little bit. Then you can start with place and hold exercises. So you can get the patient to put their thumb in full abduction or opposition, and they can hold as best as they can for a few seconds. Once they regain full motion, then you're going to start looking at another grade 3. You're going to start looking at encouraging normal movement patterns. So for this, you're going to go back to those same dexterity activities that you were doing before, but now the patient is going to concentrate on doing it properly with proper thumb adduction, proper thumb opposition, so that they can start to teach their brain to use those muscles correctly again. And then once they have grade 4 strength, they can handle some resistance, then you're going to look at strength training, like maybe with a pig or something like that. So what was the outcome? Did these exercises help these patients? Okay, so for Palesa, she's one of my current patients, so I'm not sure what her outcome will be yet, but Nero I saw quite a while ago, so I can tell you how he did. Unfortunately, he defaulted therapy, but this is a picture that I took of him of the last session that he attended. So you can see that his opposition is improving quite nicely. He's not touching the side of his finger anymore. He can now manage to touch almost at the fronts. So we can see that his motion is being regained. His sensation also improved, and he managed to develop really good dexterity. He could manage to handle very small objects quite accurately. And he was also managing well at school. So he could manage to write quite nicely. He just complained that sometimes he got a bit tired if he had to write for long periods. Okay, so recovery from a nerve injury is a long process, but as you can see, therapy can make a big difference. Thank you.
Thank you so much, Nicola, for your excellent presentation. I always enjoy your case studies and always enjoy your case studies, and your train of thought is very easy to follow, so thank you so much. I'm going to introduce our next speaker, Dr. Kirsty van Stormbroek. Kirsty is also a familiar face on this platform, but she hasn't presented for us just yet. So Kirsty graduated from UCT, and then she did her ComServe in a rural area in 2006. She worked for quite a long time at the Grooteskië Hospital hand therapy unit, which is a very busy unit. And during her time there, she really realized that hand conditions are symptoms of greater social problems and inequities. Most recently, she worked at Wits University for about a decade, on 10 years. And during the time, she was my neighbor. And she was imparting her knowledge to the next generation of OTs. And last year, she completed her PhD, which looked at developing guidelines for the support and development of generalist OTs. So I'm sure you can make some connections from Kirsty's PhD to the open hand therapy platform and the need for it. It's all very research informed. She's recently moved back into clinical practice, and she is locuming at a hand therapy practice down in George. In her free time, Kirsty enjoys a good DIY project, and like Nicola, also enjoys the piano. Kirsty, we're so excited to have you present. You're welcome to share your screen and go ahead.
Good evening, everybody, and thank you so much for this opportunity to share a little bit more about thinking through sensory re-education after median nerve repair. And sometime before 2010, I have to admit that I had a realization that I had completely forgotten about sensation in treating my patients with median or ulnar nerve injuries. I was a young therapist working at Grooteskië, and I might have seen disorganized movement, incoordination, things that I couldn't put down to just motor loss. But it didn't click that I hadn't attended adequately, apart from just the protective functions, attended to sensation. And amazingly, Birgitte Rozen, who is a giant in the field of sensory re-education, visited South Africa in 2009 and did a course that taught many of us some of the basics of sensory re-education. So tonight I'm going to get to what I learned there, but before I get there, I want to address two other quick things. So the outcomes for my talk are based around one tool that you can use to keep your focus on function. I hope that you get the feeling that we're passionate about keeping hand therapy about patients and their daily function. So an outcome measure you can use for that. Then a simple sensation test. We were taught to use Semmes-Weinstein monofilaments, but very few people have access to them or have time to conduct that assessment. So I'm going to share a simple test with you, and then I'll spend the bulk of the presentation on sensory re-education after nerve repair, peripheral nerve repair. So what is this outcome measure? So once again, this is actually an old outcome measure, but I learned about it exactly 2 months ago. I was privileged to go to the Hand Therapy Congress in the USA, and I've always liked the Canadian Occupational Performance Measure because it's very client-centered and patients are able to set their goals, but it can be quite cumbersome in practice, and it often, when you have limited time, it doesn't always work that well. And so you might recognize this image. This is the International Classification of Disability and Functioning. And when we have a median nerve injury, we're very interested in the motor loss and the sensory loss. And now I'm interested in this case with sensation because that's what I'm talking about. But it's very easy for us then to forget about assessing clients' activity and participation restrictions. So the patient-specific functional scale is a patient-derived outcome measure, and it is used to quantify, to give a number to an activity limitation and a functional outcome for the patient. It can be used with any orthopedic condition, and it has been found to have adequate validity, reliability, and responsiveness to change for the individual client that you're working with. So not to compare clients and compare groups of clients, but for that specific client. So basically how it works, with the client, you identify, some places say 5 activities, some places say 3, but with the client you identify activities that they're having difficulty with. So for one client, perhaps she is struggling with fetching water after her median nerve injury. She might really be struggling with wringing out washing, an action that really requires the good positioning of the thumb. And if this client lives in rural Eastern Cape, then she cindering her floor, so creating a polished layer for the floor of her hut is a task that she would do on her hands and knees, and it's quite a heavy task, and she would likely have difficulty with that. And with this outcome measure, you write the date that you're doing it, and the patient then, on a scale of 0 to 10, rates from 0 unable to perform the activity to 10 able to perform the activity at the same level as before the injury or problem. They would rate on that scale. So let's say she rated fetching water at, she's about her level of functioning around a 4, bringing out washing at a 5 because she's thought of a great new way of putting the wet washing in a crate and standing on it, and that drains the water. So it's not ideal for her, but she's getting there. But cindering the floor, that's an incredibly heavy task. She's not able to do that, so that's a 0. So how do we turn this into a score that we can use to track the patient's progress? So we develop a total score, and literally we add up the sum of the individual items and we divide it by the number of activities. So here it's 4 plus 5 plus 0 divided by 3 because we had 3 activities, and so the total score is a 3. The minimal, what we call the detectable change for using this. So to say that yes, my client has improved overall, they need to have improved by 2 points in their total score or more. Okay, And it has to be at least 2 points. Otherwise, it could have been by chance. And for a single activity, it has to have improved by, or there has to be a 3-point difference to say that it's not due to chance. But this is a really quick and easy, and even if the patient just lists one activity and rates their top activity, their top goal that they want to work on in therapy, this is a really nice outcome measure to use. Then I also want to just share with you, if you're not aware of it yet, a simple test of sensation. So yes, we want to definitely attend to activity and participation, but we also want to track the changes in their sensation after their nerve repair, okay? And the 10 test is a test that quantifies the perception of light touch, but light moving touch. So basically, the light moving touch is compared to a reference normal area. So if the patient has a median nerve injury, you would use both of their hands and you would apply light moving touch in their median nerve distribution on the affected side at the same time as the unaffected side, applying the same amount of pressure. If the patient happened to have both of their hands were affected, then you could use an area of the face or another part of the body where they had normal sensation. And then the normal sensation that the patient that is expressed as a 10 out of 10, and then the patient rates the feeling in the affected side on a scale from 1 to 10. So the normal side would be a 10, and they would compare, they would use the normal side as a reference in rating the affected area. And this test has also been found to be reliable and repeatable, and is used in hand therapy, but it's also used in emergency medicine and areas like that. Obviously, assessing sensation can be quite complex, but this is a nice simple way of going about it. Patients who have hyperesthesia, so they experience a hypersensitivity. One needs to change how we do the numbering system. So then on the normal or the unaffected hand, that would be a 1 out of 10. And the affected area where they're experiencing hyperesthesia would, or 10 out of 10 would be the maximum hyperesthesia. So basically, then you're able to track, you're able to give a number. Here I've drawn my hand, and you can record the perception of light moving touch in the different areas after their median nerve repair, to record changes over time, which is helpful for you, but most of all, it's helpful to patients because often recovery can feel quite slow, and it's nice feedback for them to see that they are regaining sensation. Now, you might say to me, a numeric scale is not meaningful to my patients, either because they do not have the numeracy point of reference to rank something from 0 to 10 or 1 to 10, or there's some language barriers, or there's some other factors that are contributing to it. So then consider using scales that have images that go with it. Obviously, the validity and reliability is influenced if you change a scale to assist patients' understanding. But if you're using the same scale or same adjusted scale with your patient across time, at least together you are able to track progress. So those are just 2 tests that I think are quite useful and are perhaps doable in a setting where you have very few resources and you might have very little time. But let's move on then to sensory re-education after nerve repair. And first thing you might say is, but my patient couldn't access surgery, and that is the reality. And then we are needing to take a compensatory and preventative approach with our patients. We want to prevent secondary complications like contractures, pain, and secondary injury, like those burns that we saw. And ultimately, we want to optimize the engagement in activity and participation in community life. So that might mean doing things differently and compensating for lost movement to fast track patients to achieve their goals to get back to their life roles. Also important is to document each case where you had a client who was not able to access the hand surgery that they require, because we are needing to collate evidence to advocate for the extension of hand surgery services in South Africa, but in all low to middle income countries. But now on to patients who have been able to access a repair, surgical repair of their nerves. And I would like to just acknowledge that I have used a lot of the information that I'm sharing tonight from this home program handout put together by Brigitte Rosen and the Lund University. It's quite old now, but I find it very useful and useful for guiding patients in understanding sensory re-education. But firstly, what is sensory re-education? Sensory re-education after nerve repair specifically, so it looks different, for example, in other conditions, but after nerve repair, it's the gradual and progressive process of reprogramming the brain through the use of cognitive learning techniques such as visualization and verbalization, the use of alternate senses such as vision or hearing, and the use of greater tactile stimuli designed to maintain or restore sensory areas affected by nerve injury or compression to tactile gnosis. So that's what we mean when we're talking about sensory re-education. Why is it necessary? So as Nicola has shared with us, after peripheral nerve injury, a PNI, muscle or motor function and sensibility in the hand is lost. As she explained to us, the cortical map for the affected area of the hand in the brain is interrupted, and for a period it just becomes a blank space from injury until the surgically repaired nerve is grown. Sensory input to that area of the cortex is lost. And as she also mentioned, during this period, surrounding areas of the cortex rapidly invade. It's like turf wars, because that area is no longer receiving input. The area surrounding that area invade that territory of the cortex, or that area dedicated to the affected hand. And this changes the cortical map. But then new nerve growth occurs, and there is a need for the interpretation of new sensibility. And Nicola did such a great job of explaining to us why that sensation becomes disorganized, and why interpretation of new sensibility is required. Because this hand map in the brain is interrupted and has been occupied by adjacent areas. And because of the regrowth of axons, and that the hand map has now become unstructured, we need to use vision to help retrain that area of the cortex to correctly interpret the messages that it receives from the brain, or this new language that Nicola talked about. Okay, this is a little picture that perhaps just demonstrates it again. So in the cortex, there is a specific area on the homunculus dedicated to each of the fingers, supplied by the median nerve, and those are areas dedicated to those parts of the hand. Then, as soon as the injury happens and the nerve is severed, we just get a blank space, and there's no sensory input from those areas coming to the cortex. And then that is when we undertake phase 1 of sensory re-education, when there are no messages coming from the hand to the brain. But then as the nerve regenerates and some messages are starting to be coming through to the brain, those messages are disorganized. And Nicola talked about this patchwork that looks very different from how it looked in the beginning. And that's why we need to undertake phase 2 sensory re-education. So this basically shows us again what was a really well-structured, organized cortex for the different parts of the hand becomes disorganized. And then we need to use vision to retrain the brain to correctly interpret what the fingers are feeling. So both phases, phase one, when there is no sensation, perceptible sensation for the patient, and phase two. These are programs that we develop with our patients, and we develop exercises or activities with them that they do several times a day that need to be completed in a quiet and comfortable space that allows for concentration. And admittedly, that can be challenging in a clinic context or for clients at home that live in busy environments. But very importantly, and I think Nicola hammered on the same nail, is that these activities and exercises need to be relevant and meaningful to our clients. They need to richly reflect the client's context, their daily roles and their values and their activity profiles. So phase one, this starts from when the nerve is repaired and there's little or no sensation. The nerve might not have been completely severed, so there might be a little bit of sensation, but there's little or no sensation. And our goal in this phase is firstly to prevent injury, okay, because we have no protective sensation. But in terms of sensory re-education, it's to activate and maintain the affected cortical hand map. I like to think of it as keeping the territory committed to the median nerve. So maintaining the turf in the cortex for the median nerve. And this then later enhances relearning once axons of the repaired nerves have reached the palm and sensation begins to return in the hand. So in phase one, how do we go about this? We give the brain, how do we activate that area? How do we maintain that territory? We give the brain the illusion of sensation. We do this by watching others, or our patients do this by watching others touch objects and thinking about, intentionally, mindfully thinking about how that touch would normally feel, okay? And I think the best way to do this with patients is to role model this in a session with them. Consider Janine Haro, who did our last month's the webinar, reminded us so well of this. Make a cup of tea with your patient, make a cup of coffee, and model these techniques with your client as you do it. Otherwise, it can be quite abstract for our clients. So that's phase one. Then another way of maintaining that territory in the brain is by closely watching the insensate hand being touched by various objects, textures, and repeating this often during the day. And these little bits and pieces, I hope that this is in my camera now, I keep in the clinic, and this is just a tongue depressor with a number of different textures stuck onto them. And I also use this for desensitization, aspect that we're not covering, oh, beg your pardon, but an aspect that we're not covering tonight. But this can be helpful. So the patient then strokes the insensate area and imagines what that would have felt like. They might then stroke it with the rough part of the stick that's got a bit of sandpaper on it. And this they can just keep in their pockets. Another cheap and cheerful little thing that I use are a little styrofoam foamolite blocks with different textures on, and similarly they can use these to watch the insensate hand being touched by these various objects and textures. These little guys, I've got duplicates of them, so I also use them in phase two, which I'll tell you about as well. Then another way of going about this type of training or giving the brain the illusion of sensation is about allowing someone to touch the affected and unaffected hands simultaneously. And the patient closely watches this and attends to the sensation. So they are feeling and they're perceiving and interpreting their sensation in the unaffected hand, but they're watching it happen on both the affected and unaffected. Okay, and lastly, we can do this by using a mirror. So a mirror that is positioned in the body, in the patient's midline, and the patient watches the unaffected hand. The affected hand is behind a screen or behind the mirror, and in the mirror they watch the unaffected hand move, So do movements, feel, and manipulate objects, creating the illusion for the brain that it is the affected hand that is doing that movement. So here, mirror boxes can be very easily made. They don't necessarily need to be made to be boxes. The first example here is 2 thin pieces of styrofoam with a lightweight mirror stuck on the one side, and then tape that's taping the 2 pieces of styrofoam together, and 2 pieces of tape at the bottom that holds them together. The third picture here is a lever arch file, also with a mirror pasted to the one side with tape, and just some tape holding it up. And another really easy way, if you think of the exercise books that they use at school, the hard cover ones, if you just stick a lightweight mirror to the one side, you can literally open the book and it can stand like that. So it's really easy to do and to make low cost ones that we can give to our patients as well. So again, here we want to do movements, manipulation, and feeling objects that are reflective and appropriate and relevant to the client's daily occupations. So the last way is to give input to that part of the brain is by substituting other senses for the absent sensation. So here, for example, I am manipulating a rough object with an affected hand and closely listening at the sound that it makes. So styrofoam is actually, if you hold it to your ear, it's really loud. Or sandpaper, it's really loud. And in high income contexts, they actually have sensory gloves that you can wear on the hand when retraining or when training in phase 1 that amplifies the sound. I know that some colleagues in South Africa have just used a stethoscope to amplify that sound. But to be honest, even when you just put when you touch something close to your ear, it is actually really quite loud and quite audible. So using that auditory input to create input for that part of the brain. Then moving on to phase 2. So when do we start phase 2? Phase 2 commences once the axons of the repaired nerve have reached the palm. In other words, there is some sensibility in the palm. And what is our goal here? So our goal changes here, and that is to reorganize that disorganized cortical map and relearn the ability to accurately interpret sensory input. So how can we do this? First of all, we can attempt to localize touch by touching an area with affected sensation with a blunt object like a pen or a pencil. Move the object and press quite hard so that the patient is able to perceive the input, and then compare the sensation to an unaffected area. The patient then is encouraged to focus on where the input is being perceived, what they are feeling, and how they are feeling it. Okay, and the patient, you complete the above with the patient, first of all using their vision, and then do it with their vision occluded, so just closing their eyes. And they are to concentrate on the location and what that sensation feels like, the nature of that sensation. So that's one way of achieving this aim. You concentrate these exercises to the specific areas in the hand, and then once you have achieved, once patients have correctly localized within that area, you move on, you move distally, and then allow the patient can then allow others to apply the stimulus and complete the instructions that I've just worked through. Then once protective sensation hasn't just returned to the palm, but has reached the fingertips, we need to start helping the patient differentiate between textures and shapes. And ways of doing this include touching a hidden object, shape or texture, and identifying it. So literally picking something up without vision and identifying what it is. That could be in a little box here of confetti little punched bits of paper. The patient could put their hand in and take something out and feel it, or and attempt to identify what it is, obviously knowing the selection of objects that have gone into that before the time. And this is reminding me, be sure to grade well. I had a patient a few weeks ago. I jumped into this phase of sensory re-education appropriately, but I jumped in and I graded too high. And the patient burst into tears when she got the first, when she incorrectly guessed. And in a way, it turned out it was good, because I realized that there were some psychosocial factors that needed to be addressed, but it was a good reminder to me that keep your grading low to start with. Keep things easy, and upgrade quickly rather than going in at something that's too difficult for the patient to identify, and then getting that negative feedback. So the patient can then touch a copy. In the picture here that you see with numbers on it, I made a strip of wood of numbers, and then individual little discs. So the patient will have the long one in front of them, and then they will have a little screen, and you can just even use the mirror screen, and behind the screen they will be feeling each of the little blocks, and trying to ascertain which one of the numbers in front of them they are feeling with that affected hand. So the one with that's the one with numbers, and then there are a number of other ones in these pictures. So there's ones with varying textures, from a velvety texture to rougher textures to varying levels of sandpaper, in the sort of orangey blocks. Then on the right hand side, a selection of buttons with different textures on the buttons, and patients quite like. There's an element of, last week I got 4 out of 5 right, or if you grade them nicely, that the patient gets really helpful feedback about their interpretation of sensation improving. And yeah, obviously that if it is too difficult, then you incorporate more vision into the activity. So this is just an example of a little screen, two wooden rods with a piece of fabric over, that allows the patient to have the sample in front of them, and then behind the screen with their vision occluded, to manipulate the various objects or textures so that they are able to guess. And I realize I am running out of time, but we're almost there. Patients can also carry a few objects in their pocket and attempt to correctly identify them through the day. And then another way is using all their senses to support their perception of touch again. So when they are peeling a nachi, to smell the peel, to feel the waxy layer, to taste, to hear the roughness of sandpaper and foamolite, to hear a chip crunching, to feel the greasiness of a samosa, to smell the samosa, to hear it crunching, these little donuts or cook sisters, to the same idea of incorporating all the senses in helping reprogram the brain to interpret the sensation. Then just briefly, I'm not going to spend too much time here. What is the evidence for sensory re-education? In 2012, there was a systematic review. They found 7 studies, but they're all very different. And so they had difficulty being able to create a summary of those studies in terms of the effectiveness of sensory re-education. More recently, in 2021, there were 16 studies. So there has been a lot more work. Only 4 of them were good enough quality to make deductions from. But at this stage, that there is evidence that early, so phase 1 sensory re-education with mirror visual feedback combined with your phase 2 or your traditional sensory re-education is effective. But often what they use in other studies, or what they use in phase 2 is temporary anesthetics. So this is just so that you know, I don't think this is appropriate in most of the settings we work in, but basically applying anesthetic cream to an area that is adjacent to the brain and homunculus. So basically, you temporarily reduce the sensation, for example, on the forearm, and that assists the sensory re-education in the affected part of the fingers. But I haven't covered that. You're welcome to read more about it. But I think, in summary, to say that there's growing evidence to suggest that doing both phase 1 and phase 2 together is effective for retraining sensation to enable patients to return to function. So thank you very much. I'm sorry for going a little bit over time. And I'm sorry there's not too much time to discuss all of these things. And I know there are challenges with implementing these with patients, especially when there are some communication difficulties. But yeah, hopefully we can have opportunities to discuss those in the future. Thanks, Erica.
Thank you, Kirsty. That was amazing. And yeah, I know we've gone a little bit over time, so I just want to say thank you again to Nicola and Kirsty, and thank you to everybody who attended. I'm just going to share my presentation to close off. Yeah, just a reminder that you will receive a link to the recording by the end of the week. But the webinar will also be made available on YouTube, so please share our YouTube page with anybody who might be interested. Our next webinar is on the 1st of July, and it's going to be the claw hand challenge, how to regain function after ulnar nerve injury at the wrist. And there's just some of our contact details. Please follow us on social media. We're very excited to have reached 600 followers on Instagram. But yeah, a lot of opportunity to watch our previous webinars on YouTube. And if you want to receive our monthly newsletters, which will also have the registration links, you can scan this QR code on the screen. Yeah, and thanks again, everybody, and have a good evening, and see you next month.